Okay, ladies and gentlemen, thank you very much for coming to this talk today. I'm Nick Holt. I'm the Associate Dean of Research in the Faculty of Physical Education and Recreation. And it's my pleasure to introduce for the PER Alumni Speaker Series, Dr. Jeff Redding. Jeff has an appointment. He's a professor at Simon Fraser University, but he's also the inaugural chair of the British Columbia First Nations Health Authority in Heart, Health and Wellness, which is funded also by St. Paul's Hospital in Vancouver. So one of the major reasons Jeff is here is that he has a Bachelor of Physical Education degree from the University of Alberta. It is a BPE, right? Yeah.
Yes.
In 1983, and we just went through that hallway where there's the graduation photos, and I didn't ask you, was your photo? Yeah, it was. It was up there?
The name was there, the photo wasn't.
Oh, okay, you might, yeah, well. So graduate in 1983. The university's changed a little bit since then, but we did have the Butterdome. He also has a Master of Science and a Doctor of Philosophy in Community Health Sciences from U of T. And Jeff's played a pivotal role in the introduction of Canadian ethics guidelines for Aboriginal health research and has made some significant, important contributions to the field. So please join me in welcoming Professor Jeff Redding for the PER Alumni talk.
So does this, well, first of all, thank you very much for having me today. It was a pleasure to get on a plane from Victoria this morning and come up on a direct nonstop flight over the beautiful blue Canadian Rockies and then land here. It's just been wonderful so far. I think I've got one, yeah, there we go. Just by way of introduction, I'm Mohawk First Nations from Ontario. My community is Tyndonega, which is on the north shore of Lake Ontario. I grew up in Toronto in the inner city there in kind of like a housing project. And my dad was a firefighter in the city of Toronto for 35 years. And my brother was captain on the fire department here in Edmonton. So he just retired and is actually relocated to Hamilton, Ontario. So, you know, it was a great opportunity for me to actually become a student here back in 1979, when most of you were just a glimmer in your parents' eyes, if they're even that. But it was a really transformative opportunity. So I was saying to my wife yesterday, she said, we're talking about this trip, and I said, here's the title, and I showed her on my iPhone. She says, oh my God, that's a long title. And it's kind of a complicated one, but I don't know. We thought we'd just do like a metaphor of the circle. The idea of going from on this academic journey that started off with a Bachelor of Physical Education here at the University of Alberta, and then now towards the end of my career, of course, professors never really retire. Later this week, I'm actually retiring, going to retirement dinner from the University of Victoria. I retired on December 31st and started my research chair on January 1st. So that's kind of, don't expect to retire if you want to get into academia. But anyway, I'm at this First Nations Health Authority, and it's quite an interesting thing that I'll be talking about. It's sponsored by the the St. Paul's Hospital, which is really Providence Healthcare Research Foundation, and also Simon Fraser. So I'd like to start it off just by showing some pictures of healthy people and engaged in healthy nutrition as well. But you know, the idea, we hear a lot about the problems and circumstances of Aboriginal youth, particularly with the suicide epidemic, James Bay and Attawapiskat and other places. And it's not unique to Ontario, it's not unique to Canada. In fact, you get the same patterns all around the world, so I'll talk a little bit about that, and I'll try to go through fairly quickly. I have quite a number of slides, but a lot of them are pictures. And of course, this whole notion of nutrition, you know, it's not just what you eat, it's the way you eat it and the way it's gathered and the way it's produced, and it holds a special place in a lot of people's lives around culture and tradition. The type of foods that we eat are a reflection of who we are, you know, in terms of our identity. And that's true of Indigenous peoples as it is of all kinds of people who have different orientations to food. And you could actually assimilate in terms of language and other kind of dominant mainstream behaviors, but actually food is one of the last things that becomes assimilated in as if you ever actually do, and oftentimes people just don't. So food is a powerful thing, and it's obviously powerful, I don't have to tell this audience, in terms of the health-giving effects of it, or the disease-producing effects of it. So it's really important, and I just put this up here, prenatal and natal nutrition is critical, to optimizing developmental trajectories. So I'm going to come clean. I was born in 1956. And if you do the math, that means I'm going to turn 60 this year. And this is the kind of world that I kind of was born into back in the day. 1958, this guy here is John Kenneth Galbraith. He grew up in a rural town in southwestern Ontario, and he was a brilliant Harvard economist. And he basically started the war on poverty, right? And he wrote this book. The book was called The Affluent Society. The original title was Why the Poor Are Poor. And he said to his wife, I'm going to write this book, and it's going to be called Why the Poor Are Poor. And she convinced him to call it The Affluent Society because it was too negative a consequence, the context was a bit too negative, why the poor are poor. Anyway, it became a very important document because it started to address some of the determinants of health. And these are people, this is Nehru, he was the Prime Minister of India, Lyndon Johnson, of course, you guys know who this is, right? Okay, yeah, JFK. So, there was a notion that that society actually had a role in addressing the needs of others who were less advantaged. And I think it was the post-war, World War II, Korean War environment where, there was a sense that we were in this together. The United Nations had been created, all that kind of thing. And I just bring this up, and I think, to some extent we've slipped back quite a bit from where we were in terms of our social well-being and our connections to each other. And you only have to look at the American kind of Republican race there. I'm not going to say much about it, but I think it's not the same level of statesmanship and sort of egalitarianism that was evident back in those days. So it kind of, people of my generation are kind of like that, and I think people, maybe your generation are too. I'm starting to see that around the environment and stuff. I did put this up here because there's a person here, Q Young, who's the head of public health here at the University of Alberta. And he wrote, his first paper that he'd ever done was with a guy named John Frank at the University of Toronto, and it was looking at cancer incidence rates in northwestern Ontario. And the year that this was done was 1983, published in the American Journal of Public Health. That's the year I graduated from here. So I had no idea coming out from phys ed that I would actually be, citing this about, 35 years later or something like that. But it was important that attention was being drawn into these ideas of chronic disease and conditions affecting people living in remote and isolated communities in northern Ontario and northern Canada. So this is just to remind me that when you come from a background that doesn't have a lot of privilege like I did, you sort of have to find your voice, right? Because you're not normally expected to have an opinion about very much. You're expected to earn an income, provide for your family, but not to aspire, to things like being a professor at a university or giving talks, at Alumni. That's not something that was something I had planned to do. But I really credit this idea here is that I saw this the other day and I thought that's perfect. It's kind of like finding your voice, and I think education does that. And for Native students and non-Native students, you really need to get the confidence. And I think that provided me, when I got out of my phys ed degree, I felt I had the confidence to go out and change the world. And I think that's the transformative effect of education. So I think some of you probably experience that yourselves. So I think that what I like to do in my career is, and you'll see these little balls come up from time to time, but discovery is like advanced knowledge, new research, discovery. Applying that to treatment, improving opportunities, either engaging in health promotion or the determinants of health, trying to work the policy angle, or looking at programs like food security or clean water and housing, the determinants angle, or looking at medical services and advanced, and we'll talk a little bit about all those areas. And then this other notion of advocacy. So you're kind of using evidence, new evidence, discovery science, you're applying it here, and then you're actually going that extra step of advocating for the clients or for the programs that you want to do. And this is true of anything that we do as practitioners in this area. Like we advocate for people that can't advocate for themselves. That's the reality of it. And it's good because, you will have an impact, but you'll never meet the people that you are impacting. The population level work is really important because it's the kind of thing that has indirect effects. You can't even measure it, to be honest. You do a health promotion or wellness, you can't measure an event that never happened. So you can actually try to allude to it, but it's important. So I think over time you can look at trends in communities, especially at-risk communities, and start to see things improve. Sometimes actually they will get worse before they improve because you're peeling off the layers of problems that have not been addressed and people have been out of the system and not counted at all. So that's something we'll return to. So this building, not far from here, was built for Universiade or whatever it was back in 1983. It was some big student games that were held, the Butter Dome. So that was the year I graduated. This is Pembina Hall. I was in a little room down here, just to the side. That was my first year there, so it's kind of like coming home. But it was only men who were in the bottom floor because they were obviously concerned that perverts might be looking in the rooms of women or whatever, so that was the thinking at the time. It was all guys here, and we all just hung out together, we'd go over to have pizza on a Saturday night, but it was kind of fun. So I have good memories of that. U of A has changed a lot. I was also at the University of Victoria for 13 years, hence the retirement plan. And then this is where I was last year at the Dell Atlanta School of Public Health. And I set up an Institute for Indigenous Health there with a guy named Howard Hu, who is a Harvard-trained public health researcher, the dean of that faculty of public health. And it was a $10 million endowment, and I'll show you tell that story a little bit. But this is what I'm doing now, and it's really this opportunity. The First Nations Health Council created, which represents like some 200 First Nations in the province of British Columbia, created a health authority which actually governs the delivery of healthcare for the entire province. So over $600 million every year gets transferred from the federal government to this First Nations Health Authority to run what the federal government used to run, which was the regional health delivery system. And they're very much community-oriented, community-engaged, and it's really about reimagining what a healthcare system could do from a wellness perspective. So I left this great opportunity at the University of Toronto to go there because I've been wanting to do this for some time, and it's really about that discovery, advocacy, and treatment. So just dialing it back a little bit, this is the Canadian Institutes of Health Research. This guy here is Alan Bernstein. He was the first CEO of the CIHR back in 2000. And he's actually not a health researcher at all. He's a mathematician. But he turned out to be this amazing genius in cancer research at the Mount Sinai Hospital. He also plays the cello pretty good. And these are the 13 inaugural scientific directors. So Diane Finegood in Vancouver is the head of the Michael Smith Health Research Foundation there. Remy Curion up here is somewhere around here. Yeah, he's there. He's head of the Quebec Research Foundation. Baggy Singh was here at the University of Alberta. At the time, so was Diane. Anyway, it was pretty exciting because it was the Medical Research Council before 2000. They had $300,000, or 300, what was it? $350,000 a year in annual funding, I think it was. And that was ramped up to about $1 billion in funding over an 8-year period. So there was lots of new money, and there was lots of new programs, and each of these institutes, you had a cancer institute, a heart institute, but we also had an institute for public health and population health and health services research. And I was there for the Institute of Aboriginal People's Health, and it was the only institute that was devoted to Indigenous people's health anywhere in the world, and it still is the only institute. There were about 40 different institutes that put proposals forward to be institutes, and these 13 were selected. So that was kind of it was a job of a lifetime. When you're getting a chance to do something that can change, fundamentally change the delivery of something, whatever it is that you're passionate about, take it. That's my old advice. 2 words, take that opportunity, because you're probably not going to get it again in your career. And this is another picture of the same group with a few changes to it, again a couple of years later. So it was a good opportunity. So what I was able to do by working with my community and these directors was create ethics guidelines for research involving Indigenous people. We took the funding, national funding was about $300,000 a year for the entire country in Indigenous health. And it went to $35 million over an 8-year period of annual funding, so that's quite a multiple effect. And we've graduated over 200 PhDs. About half of them were Indigenous people and the other half were non-Indigenous, and we thought that was a good mix, because obviously we need to have this kind of allies, and obviously Native people who've had that experience of growing up in a Native community would be useful. One of the things that we came out with was this guidelines for research involving Aboriginal people, and this is the same document produced by the CHR. So this has a Métis piece of artwork, and this is Inuit syllabics, which was an alphabet created by the missionaries around the sounds of the words. And this is the First Nations. And we just thought we needed to kind of put them in the context of the 3 kind of Indigenous groups in Canada. But this was important because it kind of changed. Many of you know about research ethics, right? I mean, has anybody put forward their application to get research ethics for their projects? Anybody here? Yeah? Yeah, there's people. So no doubt if you saw the Tri-Council policy statement, so this was the document that guided health research ethics, and then the Tri-Council policy statement, which is actually CIHR, NSERC, and SHIRC, the 3 national funding councils have a Tri-Council, 3 councils that have this guidelines, and anybody doing research with the public funds has to be in compliance with these guidelines. And this is the chapter that involves First Nations, Inuit, and Métis peoples in those guidelines. And it actually has a number of things like the notion of individual rights, which is the tradition in health research and any kind of research from the Helsinki Declaration and on. It looked at the protection of individuals as participants in research. And this actually looks at collective protections within research, which is kind of a new kind of concept that relates to a lot of other marginalized communities in other parts of the world. Anyway, if you're going to be doing research in Aboriginal health or Indigenous health, I would highly recommend that you become familiar with this document, because ultimately you're going to need to be in compliance with it. This is the Wabakan S. Bryce Institute. This is Michael Dan, and Michael is like one of those really, really brilliant people. He has a PhD in neuroscience. He's a board-certified brain surgeon, like neurosurgeon. He has a master's in business, and he's a billionaire. So that's a pretty good, set of criteria, right? And so Michael Dan's father is Leslie Dan, and Leslie made his fortune on generic drugs. He was a pharmacist, and so if you go to U of T on College and University Avenue, there's the Leslie Dan Pharmacy building, which he built and endowed and gave to the university. So that was nice. And Michael gave the university $10 million to establish this Institute for Indigenous Health. And this was before, it was popular, before Trudeau was sort of elected, when Indigenous issues were not really top of mind, let's put it that way. So anyway, he's quite an interesting guy, Jewish background. Kenneth is his actual name that was given to him from an elder, so he's quite embraced like an Indigenous identity. It's not just something that he gives money and walks away. He actually has an active role in the Institute. And Bryce is Peter Bryce, who was a guy who tried to raise the alarm bells about tuberculosis in residential schools and produced a book called The Story of a National Crime back in 1907, showing that in some communities up to 70% of children were died of tuberculosis when they could have been treated by just manipulating the environment a bit. So those are some of the history there, but I think that was a good opportunity. And this is Cindy Blackstock with Michael and his wife Amira. And Cindy was a person, I think she's a professor here at the University of Alberta, at least she has an appointment here, but she took a very principled stand, and she went ahead and sued the federal government for its lack of treatment or lack of attention to Indigenous kids, because she showed that there was a profound underfunding for kids in care. And so when she did that, she was actually on the CSIS no-fly list and all that. She was, the people were tracking her movements, and it was reported in the press. And but she prevailed. She had there was a decision recently where they supported her case, and $110 million were allocated, to address, improve the system of children in care. So she's a real strong, courageous child advocate, and she's another person here at the University of Alberta. She's Korean. If you ever want to get into that area, I'm sure she'd be happy to speak with you. I wanted just to give you a sense of some of the reasons why health is the way it is, and it's what we call causes of causes. And we talk about colonization, so here's a map of the world, and it's the world in 1772. So what do you think is kind of unique about that? Any thoughts, anybody? What's unusual about that particular map of the world that you wouldn't see now, maybe? Like, there's only certain parts of it that are colored in, right? Yeah, so the what's that?
The colonized countries by the Europeans?
Yeah, and so as far as the Europeans were concerned, that was the world. That's how it's labeled. And these are what they call down here British possessions, French, Portuguese, Spanish, and Dutch. And of course, Alberta wasn't part of the world at that time. Who knew? But it wasn't, And that's interesting because that's kind of like ideology, right? The world is only the world if it's been discovered by Europeans. And that's kind of the way that was in 1770s. If you flash forward to 1919, these are the colonial powers. The world is different now. It's actually much bigger than it was before. And this, for example, is showing the area of the world's empires. So this is Great Britain in this little dot in the middle, and then this is the Commonwealth in relation to the actual landmass. And then this is like India, that's the British population, and the population of India as a comparison to the landmass, or the population relative size. So the thing about this is that it's incredibly honest. They're not lying, they're not saying, this is imperialism, we're going to take over the world. And so all the British and Portuguese, French, even the United States was getting into the colonial, China, So it really was a question of going across the world and utilizing these opportunities to get resources to create wealth, for the colonizers, which is fine. It's business, right? So this is downtown in Edmonton. I don't know if anybody's seen this, but it's an unusual sculpture. And what makes it unusual is that there's a certain equality about it. They're standing there as equals, they're trading goods, and often you'll go into the history books, you'll see the native person sitting on the ground, and then non-native person standing there waving a cross or something like that. But this is actually, I think, more realistic. It was about like a mutually advantageous sort of exchange of goods, you know, in an economic development. And that was the fur trade, obviously. And I think that's kind of interesting that would be. So it's one of the most, like I say there, one of the most visual representations that's accurate here in Edmonton. But of course, we've heard a lot about the Truth and Reconciliation Commission, and this was a report that came out in the Globe and Mail earlier this year, or late last year. But you know, the idea here, I don't know if you can see that, it says, genocide or not, it was Canada who authored the story of the circumstances of kids that were taken from their families and placed in residential schools. And of course, some would argue that that was a well-meaning intervention, like let's get these kids educated so that they can be participants in the economy. So it had untoward effects, you know, the family breakdowns and the multi-generational traumas, lack of parenting skills, all contributed to a lot of the problems. And you know, I think if you can imagine having 5 children in your house and your parent, you and your wife or husband, and having the government come in and take your children away. You know, I was in Winnipeg last week and they talked about digital storytelling, and this daughter of one of the children that was taken away said that it literally broke her parents' hearts. They, you know, when their children were just taken away, they couldn't give them a very good reason, they just did it. And actually, I say literally broke their hearts because it wasn't that long before they both died of heart attacks, you know, because they were just at such a loss of having their whole family taken away from them. So that's just a little bit of understanding about when you see a person who's addicted or living on the street, you might want to try to construct maybe the past, the traumas that person has, you know, been involved in. I'm not trying to make anybody feel guilty about it. It's just part of what happened, and it's not unique to Canada. It happened in Australia, it happened in New Zealand, happened in the northern circumpolar countries, it happened in Latin America and Africa. So the consequences are things that we try to deal with in health. So this is looking at life expectancy, comparing Native people in Alberta to the rest of the population, 2008 data. And you can see here over a period of 7 or 8 years that the gap in life expectancy here is about 10 years across the board, which is, you know, life expectancy is a pretty blunt measure of well-being. But if you're dying 10 years earlier, that means you're not as well as the other person who's living 10 years longer. That's one fairly basic interpretation. And here's another, this was also produced by here in Alberta, and part of a larger study. And you can see that this is comparing non-First Nation Albertans and then First Nation Albertans. And you can see there's that gap in life expectancy. And right here it's comparing it to different places in the world. So whereas for Canadians or Albertans who are non-native, they would be compared to places like Japan, you know, the Scandinavian countries, Singapore, in this area, and whereas First Nations living in this province would be compared to, you know, living in Jamaica, Grenada, Paraguay. So middle-income countries within this context. And this was in a time when the actual economy was booming. It wasn't, this isn't a recent slide. So I think these are some of the reasons that compelled me to go from being like a physiologist working in a hospital to being a public health advocate working in Aboriginal health. So I'll go into a little bit about that. And here's another paper that was done in Australia, just basically comparing people who've had acute MIs, like myocardial infarctions, and looking at you know, their access to the healthcare system and showing that there's, for some reason, different levels of access to getting the proper healthcare attention based on clinical guidelines. And when we look at the risk factors in this other study from New Zealand, I think it's Australia there, actually this might be from Canada, you have different levels of geographic remoteness, and this is socioeconomic status. So it's controlled for those factors, that being the baseline, but you're seeing Indigenous versus non as having, even when their remoteness was controlled for, profound differences in cities, regions, inner regions, outer regions, and remote. And the further you got away, even though you, as I mentioned, already corrected for the remoteness itself, there was this huge disparity there. And then if you're looking at socioeconomic status as the controlled factor, you're still seeing variations that are pretty significant. So this tells you that there's something else is happening besides just those factors of socioeconomic status and remoteness. There's issues around cultural safety, around access to care. And of course, these are some of the risk factors that are driving. So you have a scenario here where you have high numbers of predictive risk factors. You have higher numbers of incidents of treatable problems, but lower levels of access. So you multiply the access rate by the, if it's a half-time access and a threefold higher prevalence, you have a six-fold difference, right? And that's the problem. That's why it's a crisis, because it's actually not being addressed. And so we have to think about ways to address it, because frankly, that kind of scenario could bring down the whole publicly funded healthcare system if it gets unchecked, and not to mention all the needless suffering. This is another example from the north here, or from northern Canada, First Nations, Inuit, and Métis, just basically showing a number of, the baseline would be this flat curve, and they're looking at smoking status, obesity, and self-perceived health, and you can see that there's differences in higher risks. The point is you can actually address those differences, and that's what a lot of you guys are trained at doing. But I think it needs to, it's not just an individual who can do it. There needs to be policies associated, needs to be strategized in terms of getting things done. So that leads me to this kind of opportunity that I'm doing now, which is Simon Fraser University partnering with St. Paul's Hospital and this health authority. And these areas here are not, they're not proportional or anything like that, but it's meant to show that there's significant interaction between the mandates, and there's sometimes threefold. The downside is I actually have three different sets of bosses who want to tell me what to do, which is fine. I can take care of myself. But it's great because you've got the physicians at St. Paul's, the cardiology people. These are type A people. They want to get people well, fixed now, yesterday. Let's do it. These guys here are looking at policies, trying to figure out how to manage and administer almost $1 billion health delivery system, and trying to get better outcomes. And then, of course, you've got teaching and research, which goes on at the university, and trying to create new knowledge and mentor the next generation. So it's kind of an exciting environment when you start to imagine the interactions that can be imagined. As a student or a new investigator coming into this environment, you could actually bring in resident cardiologists here, you can bring in health administrators here, policy people, and you can bring in academics and different things from different sets of disciplines, integrating social sciences with epidemiology and public health. This is a piece of artwork. It was the games up in northern BC. I think it was the Canada Games that were held there, 2015. And what I was impressed by this logo here was, that's actually an anatomical heart, right? And but it's even, they got the arterial blood as red and the venous blood as blue, and going to the lungs and all that. And I thought, wow, that's really a cool kind of depiction, not one I've seen before. So it shows me that there's people who are interested in actually improving their heart health and well-being. So I wanted to sort of get my thinking together on the current state of Indigenous health. So I wrote this paper last year on Canadian Journal of Cardiology, looking at this growing crisis about some of the things that I've talked to you about today. Notice I put in my BPE there from the University of Alberta. But it, it's really sort of like a mini review paper, but also a bit of a commentary about where we need to go in terms of improving, some of the food security issues, some of the physical activity guidelines need to be improved for this vulnerable population of youth. Of course, those of you in anatomy and physiology will recognize this as the cardiovascular system. Probably not your first introduction to it. This is, mean arterial pressure over resistance, which is cardiac output, or the other way around, stroke volume times heart rate, cardiac output times AVO2. Is this familiar to anybody in this room? Yeah, so that's something we all know about. And this is me in a previous life in the nuclear cardiology department of the Toronto General Hospital when I was a PhD student back in the late 80s, early 90s. And so my grounding here in my undergraduate degree with Art Quinney, and then I took a course in Victoria with Howie Wenger. You might not know his name, but he, when Wayne Gretzky, who was like the iconic hockey player, was the Edmonton Oilers, Art Quinney, Howie Wenger were the trainers for them, and they also trained the Canadian rowing. And then when Wayne Gretzky went to Los Angeles, Howie Wenger was the trainer there. So all that to say, we had these incredible world-class physiologists here doing great work, and it was the stuff, AVO2 difference, mean arterial pressure, stroke volume. Here's the oxygen uptake. I'm taking the blood samples to get the nuclear counts out of the blood to fill in the stroke volume, to calculate the cardiac output, central and peripheral. We also did muscle biopsies on the calf of these patients. So in my master's, I did patients with chronic heart failure. And in my PhD, I did a training study over the course of a year with 40 patients from the Toronto Rehab Center in 2 different levels of exercise. Anyway, it was actually quite good because when I went into that environment, I was really well prepared from what I had come from here. The basic training in this school was really excellent. And of course, you'll recognize this kind of stuff here. I just wanted to put it in. And that's why in my title I talked about coming full circle, because now I'm getting the opportunity after doing the Health Research Administration and all those other things to actually go back to what I was trained at and think about how to improve physical activity and uptake of oxygen in kids who actually just want to have fun and get out there and do physical activity. But I think it's got huge multiple public health impacts around avoiding everything from diabetes and heart disease, cancer, any chronic conditions, including mental health and risk-taking behavior. So I think the work that you're doing is extremely important, and it really grounded me in order to become a scientific director at the CIHR, because I had always come out of this place with a holistic appreciation of health and well-being, not merely the absence of disease, but actually a state of well-being. And that's something that we learned. So it's really, I took this with me, again, connecting different kinds of institutions with different kinds of mandates with a kind of a wellness idea. So you got the methods and tools of advanced science, you got the world-class rehab environment for patients who need that care, and then you have academics, colleagues, fellow students, and trainees. You pull that together in a matrix and you've got a very powerful intervention, and that's what I'm really grateful that I was able to do, and I guess I got the inspiration from being here. So of course the vascular system, the heart itself is a muscle, as we all know, and it has coronary arteries that supply the muscle, and it works 24/7, 80 years, doesn't stop. If it does, you're in trouble. So every time your heart beats, when it relaxes, these coronaries fill. They can't fill during the beat because it's too much pressure. So when it relaxes, the diastole, that's when the blood goes in there, right? So the problem is you get blockages that get in your heart if you have genetic predisposition, bad diet, all those kinds of things that we know about. And this is ST depression that you see, and it can either happen at rest or when you exercise because of the lack of blood flow to the coronary. So this is a catheter going into the coronary artery, and this is revascularization of that artery. So here's the real estate. That's the muscle, the heart muscle that depends on the oxygen for its own function. And then this is the part when it gets revascularized. So we all know this, right? This is all old hat. And then this is some of the new technology that's been approved by the FDA in the States. So the catheter goes into the coronary, it opens the balloon, it actually puts in a stent, and this stent stays in there for about 3 years, and then it slowly dissolves, just like a stitch. And it actually is gone after those 3 years, and then the healing of the coronary is complete. Why am I mentioning this? Well, it's kind of related to my work, but when I graduated from my undergraduate degree, I went to do cardiac rehabilitation at the North and at the Royal Alex Hospital, and then went to the cardiac cath lab when they were starting to do angioplasty. And this is another Alberta study that I wanted to share with you, likelihood of coronary angiography among First Nations patients with acute MI. And what this showed here in the results and interpretation, First Nations people are less likely to undergo angiography after acute MI. So this is within the 24-hour window of having a heart attack. That's really critical, because if you're not treated in that window, you can, depending on the size of the MI, you can die, or you can have significant morbidity associated with it. So this was done by a whole team here at the University of Calgary. Lindsay Crowshoe's a native physician, a friend of mine there. But so there's an issue here. It says, after acute MI, and experience worse long-term survival compared with non-First Nations people. Efforts to improve access to angiography for First Nations may improve outcomes. Yeah, that would be right. But the thing is, once they got access, they were treated like everybody else. There was no overt racism in the system, but there were a number of factors which need to be investigated as to why they could be related to geography, access to care, a number of things that need further investigation. But that's an important study, because these are people with lives. They have grandchildren, they want to be around for them. And it's a question of a publicly funded healthcare responding to disparities. Here's another, this is up in the Tiwi Islands. In 2013, I spent a year in Central Australia working for the Diabetes and Heart Institute, Baker Institute. And this is a completely preventable problem. The kids have open heart surgery when they're like anywhere from 6 to 8 years old. It's rheumatic fever, which is treatable, but if it's not treated, it actually erodes the valves of the heart. So these kids end up with, surgery and cardiology for something that's really related to their social circumstances, their living conditions. And it happens in Canada, but it's not really been studied. So this is a cardiologist, non-native woman, who went up into the north end of Australia and started to look at these kids, and it's really, this was published in The Guardian, I think it was about a month ago. So the other aspect of this has to do with the fetal circulation, and you're talking about, a fetus that's being completely dependent on the mother during gestation. And here we have all these kind of defects that occur in the first trimester if a person isn't actually, person's involved with drugs or alcohol, that can actually affect the fetus. It's obviously not unique to Native people, but there is a higher proportion, but it's also prevalent in mainstream. So people often don't know that they're pregnant in the first trimester, and they're carrying on, part of drinking is socializing, right? And that's a problem, and that's obviously an easy fix if we know what we're doing. And so occasionally I go on a bit of a rant in the Canadian Medical Association Journal just to make sure that I can keep people thinking about these topics. But here's a thing from the UK looking at the different causes of death and trying to put them a little bit into perspective. And I think it's a powerful visual, that you can take out where you're looking at, these are all chronic conditions, and some of the other conditions get a lot more attention, but yet in terms of the burden of morbidity. And these are some of the risk factors that are leading up to those conditions, so all the things here are the things that we try to turn our attention to in physical activity. So we're doing preventative medicine, influencing these leading causes of death. Not to say that it's a complete cure or anything like that, but we know that it has, I'm preaching to the converted, we know that it has a huge impact. So we go through this sort of life course, and for a lot of Native communities, this is a bit of a myth. it doesn't really go this way. I mean, there are more challenges at different stages. So one way of thinking about health and well-being is to look at life course as the long-term consequences of different kinds of exposures timed at different stages of your life. So for example, looking at exposures, either physical or social, at gestation, childhood, along up until elders. And it goes beyond these traditional risk factors and looks at some of the other things that need to be measured in terms of well-being, like birth weight and intrauterine nutrition. Like, those are things that don't normally turn up in a list of indicators, but those are the kinds of things that have huge impacts. So there's a paper here by John Frank and this group here that kind of looked at these causes of causes from societies to individuals, upstream forces. And the reality is, if you're going to invest limited resources, the earlier you can do it, the bigger bang for the buck, right? I mean, that's, put it bluntly. So it's really important for women of childbearing age, who, especially if they're in a relationship and they're wanting to have children, to be very careful about, what choices they make in terms of if they do get pregnant. And I'm, again, keep preaching to the converted. But the vision here is to achieve life's full potential, right? And to add life to years. And if you add life to years, you add years to life. And, I wrote that on the plane coming up. I thought that was pretty cool. Yeah, but then, it's a challenge, right? Optimize the developmental trajectory over the entire life course. And this is just one example. Now we're getting into this, multi-generational transmission of epigenetic predispositions. Oh my God. But here it's showing, the exposure to environmental contaminants and it affecting the reproductive cells into the third generation. And if you look at the amount of research going into this area right now, it's just gone skyrocketed. Like, the NIH is going crazy on epigenetics. Some of you are probably doing this. So what really matters here is trying to address this complex interaction of biological and social factors, and other factors, which we call health determinants, in these different contexts over the entire life course. And it sounds complicated, but that's what parents do every day. That's how we all got here, because somebody they cared enough to make sure that they looked at the interaction of all these things to try to optimize the well-being of their children. And that's what parents do. And these are all the kinds of factors that could possibly go into. There's a whole bunch more that you can imagine, but it's a complex thing, being healthy. It's not just something that falls out of the sky. You got to actually think about it and try to create environments. You think about that at the individual level. Try thinking about it at the population level, the province of Alberta or the country of Canada. So it's a big challenge, but I think it's one that we're well equipped to deal with. I think I'm kind of running a little bit over time, so I'm going to come past some of these. These will be available on the slide if you're interested, and you can review them whenever you like. I'm going to leave this entire presentation here. But it talks about different health service challenges, delivering health care, community-based approaches that might be useful to you, and they're all completely referenced here. And looking at different issues around, research specifically, looking at best practices in research, getting better data for analysis, having information in systems for surveillance and improvement of programs, ongoing evaluation of specific interventions that are aimed to improve health, and finally, taking a very careful look at barriers to achieving progress. And so there is a lot of opportunity in cardiovascular care or other kinds of care in health research, but there's this notion of, are the clinical guidelines being adhered to? Like, for the certain type of treatment of a certain problem, the guidelines are there. You can get them through administrative data linkage, but you could actually look at that. And it's important as a blunt tool, but it doesn't have it has some limits. You can actually go into more qualitative type of work where you're looking at clinician-patient engagement issues and then specific qualitative questions about the context and the different kinds of lived experience of patients and their caregivers, because it's equal. The interaction is a two-way interaction. Some of you are going to become doctors, like you're going to be or health practitioners, nurses, or whatever it is that you want to do. And you may find this useful when you actually do that. Or you could be part of teams that are delivering health care. But I think it's really important to actually think about different kinds of things as complementary to one another, but these intervention studies, physical activity and well-being, that's a really important intervention, because when you're doing that right, a whole bunch of other things are falling into place. You know what I mean? Good food security, lack of access to tobacco, probably less drug utilization, those kinds of things. So I guess there has been some changes in Ottawa, so I've heard. And we have a Minister of Indigenous Affairs, Carolyn Bennett. Carolyn is a medical doctor. She set up the Public Health Agency of Canada 10 years ago. She was the Indigenous Affairs critic during the Conservative government. And you've probably seen her in the press, leading the inquiry on missing and murdered Indigenous women. But she really gets the notion of public health and the idea that you can do health and well-being interventions on this population. So I encourage you to consider, thinking about this area. You might want to become involved. And then, of course, this is Jody Wilson-Raybould, who's the Minister of Justice. And I think she's got a pretty interesting agenda looking at, fundamentally trying to get at some of the issues, the legislative framework. It's like the Indian Act, which I didn't go into, that have kind of put people into these circumstances of colonization, which I alluded to earlier. So it's about overcoming the historical context. So we'll see how that goes. But I guess the final slide here is imagining a future where the kinds of funding, but funding is not really the right word, the kind of priority is to grow and support Indigenous-led centers for data and institutions doing research, disconnected from government interference, but also connected to the academy, like places like this. And as long as it supports this First Nation sense of autonomy, in other words, a partnership based on mutual respect, and funded with a vision to shift communities' health and well-being and social well-being to help create a sustainable future. And that's kind of, this is the last one here. It's just, this is a person, this is an adult person with a normal-sized head. And that goes to show the size of this piece of work, this artistry. And this is like more so, and he's talking about the shaman's world here, showing this thriving and bountiful world, which all the diverse elements are in perfect balance. And I guess that's one way to show that, that there's a different way of knowing when you get into kind of these cultural differences, not just with Indigenous communities in Canada, but also different kind of cultures and ways of seeing the world. And the great thing about education, it gives us a chance to have an open mind and try to learn from the work that we're doing. So anyway, I'm really grateful for the University of Alberta to give me the chance to go on this journey, and I'm not done yet. Thank you.